Thanks a million for that, Joanne. So I'm glad Samantha's in the flats because she's back up again to talk to us about the third set of key findings from the project, where we're going to take what we've learned from the analysis and examine what more needs to be known to further strengthen the evidence base for children's palliative care in Ireland.
So it says slide set 5. And there are only 5 sets, I think we're done. So this is the last one. Okay, so this is our third stage of where we are in our analysis, and it's really about pulling together, okay, what have we found? What more do we need to know? And we're doing this so that we can guide future research, but also so that we can focus on policy relevant gaps. This is one of the strongest, I suppose, positives of this piece of work, that it was grounded in a question that policymakers were asking for. And as a researcher, that's kind of gold dust, because you want to be working on something that actually is needed. So that is where we want to go. We want to, again, focus on policy relevant gaps. So what more do we need to know, and why do we need to know this? So in terms of our prevalence findings, this is taking you back to stage 1. I've shown you what we have learned. Now what more do we need to know? So the first thing is, who are we missing? So we need to identify, who are we missing in our numbers so that we can improve the accuracy of our prevalence estimates. So our estimates were based on hospital-based attendances. So obviously there will be people who were living at home, maybe in a stable phase of their life-limiting condition, who didn't need a hospital admission in that year. So we are missing those numbers. So we need to find ways of addressing how we find out about those people. So there are other data sets that are potentially usable. Something like pharmacy claims data set can maybe give us an insight. And so it's, again, knocking on the door, breaking down the barriers to access other types of data where we can improve our estimates. Where are we headed? We need to analyse the trends in prevalence. You've noticed that Lorna was able to show you the trends in prevalence over a number of years for England, Scotland, Wales, etc. We presented you with 2019, and in the report we also, in the paper, we also provide 2024. But we've been very careful to show that we can't show you prevalence over time. And that's because we're looking at discharge level data and making estimates of the number of patients. And it's not sensible to go to estimate over a number of years, because you're just making the same adjustment to a different number of discharges. So we need a unique health identifier in national hospital data so that we can analyse prevalence over time, so that we can then project for the future. Where is the supply relative to the need? So I referenced this earlier. We have estimates of our prevalence around the country, and we need to tally that with where is the supply. And that's so we can assess geographic equality and equity of services. So I just want to dwell on this point for a little bit. So what I'm showing you in this picture is really we have half the picture, and we need more evidence on the supply of specialist children's palliative care services, where they are in the country. It's easy for things like the clinical nurse coordinators. I have the numbers, I know where they are in the country and where they're based. It's more difficult for things like the respite services, the respite beds that are dotted around the country, and getting a handle on how many there are and where they are in the country. And once we get that full picture of the supply, then we'll be able to assess the supply per child with life-limiting condition. And at that point, we'll be able to make some assessments of how equitable and how equal the services are across the country. So complexity indicators have been mentioned a couple of times, and so it's again just pointing out that we have one part of the picture in terms of the number of children with a particular condition. We need to combine that with information on their care, their complexity of care needs, so that we can get an idea of how many children with a life-limiting condition might actually need access to specialist palliative care. So we're not presenting today, but we did a sort of a Delphi process, and maybe many of you responded to our survey, and thank you for that. So we gained consensus expert opinion on a set of medical indicators that are technically feasible to collect in national administrative data that can help us combine with diagnostic data to identify who might need children's palliative care. So we're publishing a paper on that, but it's about the next stage of ensuring that those data can be collected at a national level, and we can use them then to combine with diagnostic information. And then the final thing here on prevalence is who is receiving specialist children's palliative care. So this is another part of the picture that we're currently missing. We don't have individual patient level data on children receiving specialist palliative care services in Ireland. We have some high level data, but we really need some more detailed information to understand who is receiving the service, what's the unmet need, what is the reach of the service, what are the variations in referral practices. So this is all information that I think would be very valuable to add to our toolkit. In terms of what more do we need to know on hospital activity, so this is based on the information that Joanne has just presented. What more do we need to know? Why do we need to know this? As Joanne mentioned, unpicking the length of stay in hospital. We have plans in the project to do a little bit of more rigorous analysis of the factors associated with length of stay in hospital. But what I won't be able to do in that analysis is take into account the impacts of services outside of the hospital, how they're affecting length of stay in hospital. So as Joanne said, there are very good reasons why a child may need to be in hospital for a long time, where it is health replenishing and where it is valid and needed. But where there are non-clinical reasons for why a child is in a hospital for a long length of time, for example, they're waiting maybe for a specialist review, or they're waiting to connect with clinical multidisciplinary teams on the ground, or waiting to access step-down supports. These are things that need to be addressed. So if we can get information on those extra supports outside of the hospital and within the hospital, we can begin to unpick the reasons behind unnecessary long lengths of stay. In terms of the lived experience, I think you've got a sense of it this morning from Orla's just an amazing description of her life and what it is to what these numbers mean in practice. And I think, as Orla also referenced, it's a lot on her. So I think if we can get some additional research in this area that's just gathering information from people who like Laura, are living this experience, and then we can supplement that with the quantitative analysis that we've done in this project to really shed a light on. So what it does is it doesn't just present us with, oh, these are all the problems I'm facing every day. It's through these sort of discussions that we can look at the evidence that we're showing, shine a real light on that, of what that means in practice, and then come up with solutions and recommendations for changing practice. Transition to adult care to support young people and families as they transition, because this is becoming a growing phenomenon. There are more and more children who are surviving longer and transitioning then out of paediatric services, and we're finding that they are not supported in the same way in the adult system. It's a very different system, it's designed differently, and so it's very important to understand what needs to be in place to support those families going forward. So this is just a nod to it. We can't really say much from our data a lot about transition. We've highlighted that there does seem to be a growing cohort of children in the pre-teenage years, but beyond that we can't say a lot, but we can nod to saying this is a very important issue that needs more analysis and research. The pandemic effects, this is not part of this project, this is just something that you see when you look at the dip in the discharges from 2019 to 2020. It was really notable. But what was also really notable was that the decline in discharges in 2020 was much larger for the non-life-limiting cohort than it was for the life-limiting cohort. Now, there are many reasons behind that. Again, I'm not a clinician, I don't know all of them, but I'm just flagging it as this is something that's interesting to look at from a hospital management point of view, from a policy-making point of view, because, you know, who knows when the next global pandemic or issue is going to hit. And I think there are some learnings that need to happen there. So what does all this mean for policymakers and providers? So ultimately we need better data and we need more of it. So in terms of quality, in terms of better data, we need national patient-level data on specialist palliative care use by children. We need a unique health identifier in national hospital data. I'm not going to tell you my age, but I have been working in Irish healthcare analysis since, my PhD, which is a long time ago. And we have been looking for a unique health identifier in Irish healthcare data since I started. And I don't know if it's going to be in place when I retire, but I sincerely hope it will. But I think what you're seeing today is just how important it is. Did you see some of those lovely graphs that Lorna was able to present? We can't do that in Ireland because we simply can't follow a patient from one year to the next within hospital data. We also can't link. We can't identify or follow the use of patients from the GP service, from the emergency department service, into the hospital data, into their pharmacy use data, and ultimately linking with death records. This is not rocket science. This is just basic information that will help us to do a job for you that builds the evidence base that really provides you with information to plan a service. A palliative care flag, we mentioned this in our report because Orla mentioned it, Joanne has referenced it. I think what we've done in this analysis is shown the visibility of this group of children within the hospital data. On any given day, there's like 17 out of 100 discharges from CHI have a life-limiting condition. So what we've shown in the data is, we can see them now. When you group all these children together with this varied range of diagnoses and conditions and challenges, when you see them together as the group, they become very visible. What Orla's perspective brought to us was, well, I want you to see my child. I want you to see what that means when I bring my child to hospital. It means that I can't just rock up on a Thursday morning from Limerick. I probably need my husband or somebody else to drive me so I can sit in the back with my child. When I get there, where do I park? How long am I going to be parking for? When I get into the hospital, who's going to mind my child while I try and take into what the consultant is saying to me? All of that is really important. And if somebody could just see it and go, okay, how can we make that a bit easier for Orla and her family? Something like a palliative care flag or a flag on the patient chart would actually mean that somebody in the hospital is actually prepared for somebody coming in with a child that has extra needs. So it's simple things like that. These, as Paula said, these don't cost money. So it's things like flagging needs for extra support, a palliative care flag in the discharge summary that helps us from a research perspective to identify, okay, what sort of palliative care supports did this child receive while they were in hospital? So we need to look at how that flag is used. In terms of quantity, obviously I'm a researcher, I'm going to ask for more data, but we do need more data on medical complexity so that we can supplement the diagnoses in our national prevalence estimation processes. There is information on delayed discharges within the HSE, but it's a standalone data set that has no connection with the hospital inpatient data set. That doesn't make sense. We need information on delayed discharges within the hospital system so that we can start to tease out reasons why children are staying in hospital longer than they might need to. Thank you.